In this segment, I talk about triage of the chest pain patient in the emergency department. So triage of the chest pain patient seems pretty straightforward. They come in, they say they have chest pain, you get them back to the room, you do an EKG, and you get them to the cath lab if it's a hot MI. Unfortunately, this is complicated by a lot of things in terms of people who come in with that typical presentation and then atypical presentation. So your classic one is a substernal chest pain. They use that Levine sign, a closed fist right over their sternum there. They say it's heavy, crushing, like someone sitting on my chest. The Advanced Cardiac Life Support textbook says only a little over half of the MI patients present like this. So when you say chest pain patient or myocardial infarction, this is the guy you typically see. This is right out of my textbook from my first CPR course from the Red Cross. And this is the guy you think of, guy in his 60s, 70s, smoker, high cholesterol, all that kind of stuff. But it really is a lot more complex. You see a lot more patients, and I know some of you who are working out in the field or working in ERs, you're seeing people having heart attacks in their 40s, 50s, things like that. So you need to be a little more savvy than just looking for this guy with the pain in the red zone there. Not all myocardial infarctions come in and say, I'm having chest pain. Here are a few examples from when I was sitting at a triage desk and someone came up to me and said something wacky. And I said, you know, I don't know what's going on with you, but I think I'm going to start out with an EKG. So here's one. Diabetic, guy in his mid-40s, coming in and said, I just don't feel right. I'm a diabetic. I don't know what's going on. Are you feeling short of breath? Not really. Any chest pain? No. But the guy's sweaty. The guy's sweating buckets. He's dripping onto my triage desk. I was talking to one of my ER docs about this a few weeks later, and he just said, sweaty is bad. I hate sweaty. Did an EKG on this guy. He was having the big one. We needed to get him right to the cath lab. Another guy comes up, says, both of my arms feel like lead. Well, I'm thinking stroke to start out. Good grips though, no arm drift, even though they felt like lead. Clear speech, face symmetrical. Again, I don't know what the heck's going on with you, but let's start with an EKG and go from there. Hot MI, right to the cath lab, cardiac alert. Left shoulder pain, I turned over in bed and my left shoulder started hurting. I don't know what steered me in that direction, but we got that EKG, and here's another cardiac alert. I've had this cough all week, and now my chest is just burning. I was actually training a nurse in triage who works over at the local cardiac specialty hospital, and she said, let's get an EKG on this guy. I was like, oh, what the heck, let's give it a whirl. Hot MI, right over to the cath lab. Again, from the Cardiac Life Support Handbook. There are certain groups of patients known to present in an unusual, atypical manner without the classic symptoms, only with vague and non-specific complaints. Now let's look at these wacky groups that ACLS talks about here. First one is the elderly. Well, of course the elderly are they're the ones having the MIs, so they're going to have the whole gamut of symptoms. They're going to have that chest pain, but they might not have it. They might be short of breath, sweaty like my guy, just feeling kind of weird. Diabetics. These diabetics have that neuropathy, a lot of nerve damage, so they're not getting that chest pain signal. So they're the ones who are going to be sweaty, short of breath, just feeling kind of weird and off. But they could be having that hot MI. So be aware of just kind of vague, non-specific symptoms like this in diabetics. And then this is the one that always kind of kills me here. They call women an atypical population because women, they just don't have that chest pain like men do. I think their pain threshold is probably a lot higher. The wimpy guys there. Typically they're having their MIs decade later than men, so they have a lot more comorbidities, maybe even diabetes and such, taking a lot more medications. So they're going to be just feeling not quite right. Now let's talk about the implications of a bad triage decision. Here is a verdict form from a coroner in Lake County, Illinois. It's in the suburbs of Chicago, and his ruling, given a choice of homicide, suicide, accident, or undetermined, he said homicide in this case. A woman, 49-year-old, presents to the triage desk at 10:30 one night in East Vista Medical Center there. Complaining of chest tightness, must have been a busy night. They sent her to the waiting room. They got her attention, she got their attention again at 12:30 when she keeled over in cardiac arrest in the waiting room. They tried to revive her, they couldn't. So given that, the coroner called this a homicide. She died from an acute MI, which she had been having, which had been evolving from 10:30 when she showed up until 12:30 when she keeled over and died. They called it a gross deviation from the standard of care that a reasonable person would exercise in that situation. Now, just because he called it homicide, it didn't mean they were charged with murder. So I have not been able to determine, I haven't seen any sign on the internet or in the news or anything that they actually had criminal charges in this, but you can only imagine the civil judgment that they gave. The lawyer for this hospital probably got carpal tunnel from all the zeros he had to write on that check for that patient's family there. So consequently, for me, you have to have a very, very, very low threshold for saying this person needs an EKG. For me, basically, anyone with pain, any discomfort from the groin to the nose, I'm going to consider an EKG. And maybe they don't need to be slammed into a wheelchair and run over to the nearest room and run right away. But even like a 25-year-old, I've been coughing all week and now my chest is really hurting. Well, that's probably, you know, just from all the coughing and such. But I will check a set of vital signs. I'll get them back. I'll sit them down and say, I'd like you to change the scan. I'm going to send in one of my techs to do an EKG. Just want to make sure your heart's ticking along the way it should. So we get it probably within even that 10-minute window, but we still do get it. And then, of course, if they are having a myocardial infarction, they're going to get to the cath lab and get there right now. Once again, in my facility, we're hitting our targets really good. In 2007, we're about a little over half. Now the vast majority of our patients are getting from door to the cath lab and even getting those stents put in and those clots punched open pretty quick there. If you want to know more about speeding up your door to cath lab time, there's stuff from New England Journal of Medicine 2006 had a pretty landmark study looking at a lot of different infrastructure and kind of physician-centric things you can do. Journal of Emergency Nursing 2010 had a couple of good pieces about some nursing interventions that can speed that up. And the Door to Balloon Coalition has a really interesting website to check out, show you a lot of things to speed up those door to cath lab times. Now, the really bizarre thing is not all chest pain is cardiac, and that you get your 12 lead, it is negative, and everyone breathes a big sigh of relief. But there are plenty of things that are just as deadly and just as rapidly deadly as your MIs. So that's, the chest is not a simple structure. The main structures of respiration and circulation are in there. Any problems with any of them are a big thing. So that's the bulk of my lecture. If it isn't an MI, what is it? Diagnosing non-cardiac chest pain. I'll be presenting that at the ENA National Conference in Tampa in September and a couple of other places before then. So I'll see you then. Hi, if you liked what you heard here, I'm available to teach at your nursing conference, your EMS symposium, your fire department, your hospital, anywhere where healthcare professionals need continuing ed hours. My name is Curtis Olson. I'm an ER nurse and educator, and you can reach me at nursecurtis@windstream.net. Email me and I can send you a copy of my available lectures, any other details you need. Thanks for watching. Bye-bye.